Good morning and welcome to our monthly webcast. I am Samir Mehta, your moderator, and this is session number 85. We have a terrific case for you today where we plan to demonstrate BVS technology. This event has been deliberately timed following the recent FDA approval for this transformational technology. Today's case is also special that we have a fantastic guest joining us in the Cardiac Cath lab today. It's Dr. Chuck Simonton, the Chief Medical Officer of Cardiac Therapies at Abbott Vascular. I have known Chuck for almost a decade now. One of my first interactions with him was when Chuck was working at the Sanger Clinic in Charlotte, North Carolina. Chuck may not recollect this, but in 2004 he gave an outstanding lecture about PCI complications at my Lumen meeting in Miami. What was so noteworthy about this presentation that I relate about this 10 years later is that all the complications that Chuck reviewed were his own. To best teach PCI complications, he showed his own cases. This was a most refreshing and honest experience coming from a most talented and a very humble interventional cardiologist. Chuck has taken all these personal characteristics and more to Abbott Vascular, where I believe he's been working for almost a decade now. Chuck is our perfect connection with industry. Having lived in the trenches of interventional cardiology, he understands the need of a close relationship between interventional cardiologist and industry. It is this kind of a partnership that yields innovative interventional cardiology devices and brings to our patients truly amazing procedures, one of which we'll show you today. Dr. Simonton's tenure at Abbott Vascular has been extremely productive. My own and completely independent observation has been that Chuck has had 3 outstanding achievements at Abbott Vascular. I think these include the mitral clip, BVS technology that we'll demonstrate today, and the recent merger with St. Jude Medical, which happened a few weeks ago. Chuck, welcome to our webcast. It's a fantastic opportunity for us to learn BVS also from you. We'd like to teach not only the best procedural tip of using BVS, but also help our audience, much more importantly, in selecting the most appropriate lesions for this technology. Samin, good morning to you and to Anu. It's time to teach BVS to the whole world.
Yes, and actually, as we've mentioned, we are honored to have Chuck, Dr. Chuck Simonton, who has the maximum experience, knowing this technology had just arrived in US a month ago, but has been outside for last 2+ years, and there is immense data, both research-wise as well as clinical, where Chuck has participated, and I have been with him in many of the symposia, and we really welcome Chuck on today's case. So we'll take his real input, and hopefully our the CCC live webcast viewers will benefit from it. I know usually actually the live usually could be only anywhere from 50 to 300, but right, overall every month episode is watched by 6,000 people average over 130+ countries. Yep. And this live webcast has been a really educational tool for us, Chuck. So with that note, you say a few things, and then we start.
Thank you very much, Samin, and it's a pleasure to be here at probably one of the top cath labs, if not the top cath lab in the country. This is a fantastic venue here, tremendous amount of experience, and it's really a joy for me to be able to be in the lab with such talented operators and the leadership of Dr. Sharma and Dr. Kinney. So I really look forward to this case, and we'll take a look at the pictures here in a minute, but we'll step you through this and help you understand a little bit about the technology and how we can use it in this particular case of a patient with a proximal LAD lesion. So I'll turn it back over to you, Samin.
Beautiful. Okay, so we can just start with the, Anu actually has taken some pictures, but we go through our regular the disclosures and supporters, and this is a 72-year-old male who has a strong family history but very little symptoms, which led to a stress echo, because he has also heart murmur, largely because of the mild aortic stenosis, but he has anterior wall ischemia clearly, and that led to the cath outside hospital, where they found 3 lesions, one in the LAD, second in the diagonal, and third in the LPL. And they all actually had a FFR, and which was clearly positive for the LAD. Diagonal was 0.81, and circumflex LPL, which was normal, 0.87, and normal ejection fraction. And he was started on medical therapy. He's on good medical therapy. Rest is all shown here, and Anu will show the angiogram, which we have obtained now. Patient has a pacemaker. Yeah.
So Samin, 2026 he is scheduled for TAVR?
Or yes, by the definition should be 5 years. So maybe 2020.
All right.
Yes.
Anu, let's see the case.
Yeah, so if you see the left main is non-obstructive, but just before injection, lot of calcium, especially in the LAD territory.
So Chuck, here is the first question for you. Are you concerned with the BVS attempts to be placed in a calcified vessel, or this should be acceptable?
Should be acceptable. If it's concentric calcification, I probably would not recommend it at this point. But for eccentric, moderate to severe calcification with a good prep, there's no reason why you can't deliver Absorb. The radial strength is equal to the current day metallic drug-eluting stents such as Zions. So it should be fine, but the prep is really, really important to get not only delivery but also full expansion.
That is exactly what we'll demonstrate, and you agree with the use of OCT here also?
Yes, absolutely. OCT matches up perfectly with Absorb because you can get the high resolution you need in detail at the strut level to look for strut apposition and full expansion. So
also helps in the sizing?
Yes, also with the sizing, which is extremely important. You know, the BVS should only be used in vessels 2.5 millimeters and above, and for OCT that means 2.5 millimeter lumen of the reference vessel and above, and that's where the data really shines and where the technology works the best.
Fantastic.
I know. Thanks for that.
So OM is a small size vessel. Most of the disease is in OM2. That's where the FFR was positive. Again, it's a branching vessel. There is osteally significant branch of that OM, and this is where the LAD, if I can show you a better picture, prox LAD just at the level of the septal, probably the calcific significant disease. Just like Chuck mentioned, looks like eccentric, most of the calcium probably only one wall rather than you see tram track calcium, and the diagonal ostium is spared, but further down you have significant disease in a branching vessel.
Right.
This is where we are now.
Anu, you're not planning to protect to side wire the diagonal, no? No need?
Well, I mean, that's a very good point. Just to say that we have the data, it's a 0.81 in the diagonal now without interrupting your LAD. So likely the diagonal will get compromised, even if just by the scaffold in the main vessel, or even for the med any DES. So since it's 0.81, and usually you can leave that, we know the 0.8 is cut off, but we know 0.8 and 0.81, and particularly that is at the baseline, and things may change once you put a stent. So what our plan was, that do a PTCA and the regular Zions into the diagonal, and then of course after preparing the LAD, and then do the rotational atherectomy and the BVS in Absorb in the LAD. So that was the plan.
Samin, by angiography you would guess that to be a 3.5?
Yes, yeah, it is, yes, and you're right. OCT will know, but angiographically it's a 3.5 millimeter vessel,
so we'll
and that is what the balloon which we have prepared. Always we, in cases with the rotational atherectomy, you always prepare your balloon before you start doing the rotational atherectomy.
Excellent.
Okay, so with that note, now
I think we'll direct wire with the rota wire, and
yes,
we have 175 bar for the LAD. Plan should be, I think we do the rotational atherectomy of the LAD, pre-dilate it, and then we do the OCT of the LAD, and pre-dilate, stent the diagonal, but diagonal stent should be the same. It's diffusely diseased, probably go to the upper branch, take a 15 millimeter balloon and probably a 18 millimeter stent into the diag, or maybe just a 15 millimeter stent.
Or 15.
Yeah, probably a 15 millimeter stent. Then we go smaller. You see the lower branch, I think that lower branch will leave it alone.
Right.
Otherwise then it gets too complicated. It's diffusely diseased all the way down.
Right.
Okay. So now with that note, while they are trying to get ready with the rotation atherectomy, we can go over some of the plan which I mean the didactic discussion, and this is exactly what we plan to do in this particular case, the rotation atherectomy and PCI of the LED and diagonal using Absorb GTI with the OCT guidance, and clearly it's an appropriate case by our OC criteria. So 2
Samir,
points.
can you pause just at that slide?
Yes.
Chuck, I want to mention something to you here. I also brought an entire breakdown of the 85 cases what we have done. But one of the things which we have consistently maintained in our webcast is the appropriateness criteria. We emphasize it, we display it prominently, and we translate that into exactly how our procedure fits in.
Yes, I think it's extremely important. And Samin already went through the FFR on both the diagonal and the LAD, both clearly qualified for PCI. And in this patient, we would recommend using a metallic stent in the diagonal branch. It's pretty close to 2.5. It may be a little less than 2.5 as you get out more distally in the branch, which would be preferable for a metallic stent as opposed to absorb. In the future, we will have a BVS that will have thinner struts that will allow you to treat these smaller vessels, probably within the next 2 to 3 years in the U.S. So it's a great opportunity in the future, but right now I think it's best to treat this with a metallic stent and place the absorb in the LAD, which for the patient is really the most important vessel anyway.
Excellent.
Good. Okay. So all right. So while we got the guide in and trying to go through our rotablation, so 2 points wanted to discuss. Basically, of course, the update in your Absorb BVS approval. So what actually the FDA has given us the guidelines, what we learned from the studies and so, and of course most important being the update on the implantation techniques, because a lot has been said. They have a higher stand scaffold thrombosis and so, but at the same time I'll share the data with you that you can change that concept of scaffold thrombosis by your BVS specific implantation techniques. And the second, we'll talk on the data on the impact of IVS and OCT guidance for the PCI outcomes. So we actually in March we did present the Absorb in our didactic discussion of our March case. So which we all understand that whole concept of the bioresorbable vascular scaffold is that there is no metal cage on the long term, and particularly very useful for younger patients, so they can get the elasticity of the vessel, normal vasomotion, and besides many others which could be a decrease in the dual antiplatelet therapy after 1 year and so forth, and the whole concept of the radial strength which we don't need after 6 to 9 months, so that it start disintegrating, and of course the full absorption takes place in 3 to 5 years. So actually I'll pause here and ask Chuck on this issue, because this actually has been some people believe that the scaffold will get absorbed in 2 years, 3 years or 5 years. I know earlier we used to just say anywhere between 24 to 36 months, but
right.
Now some data are coming that really absorption occurs by 5 years.
Yes, 3 years. There's no detectable polymer in any of the preclinical models that we've tested, or even on the bench at 3 years. So completely undetectable by 3 years. We know at that point. But you know, the vessel function starts to return as early as 1 year. So it's already starting to do what it's programmed to do, which is to become discontinuous and allow the vessel to take back over the function as early as 1 year. But all the polymer is completely resorbed at 3 years.
And I think that's a very important point, because the data which we shared in the past showed that while you have still absence of vasomotor function by giving stimuli, whether acetylcholine or nitroglycerin, so that after 1 year, because of the disintegration of the scaffold, you start getting those vasodilatation, vasoconstriction in response to the appropriate stimuli. Now we knew that Absorb 3 trial, which was done here in United States, clearly showed that overall there was a scaffold thrombosis. This was again very early experience. There was a lower the outcome, the device related outcome, particularly deliverability of the stent, the success of the scaffold because of the stiffer. And now as you saw that this new GT1 has clearly the better deliverability on which, just like the science has been the usually implanted. So same shaft delivery system which we have seen now, because we are still part of the Absorb 4 trial, which is I'm sure finishing its completion, and now the GT1 Absorb system definitely is we can feel, Chuck, the delivery of the between two of them.
Yeah, yeah. You can. The key difference in the delivery system is the hypo tube, which you're actually holding and pushing, is more supportive, a little more rigid, and the actual plastic part of the catheter from the RX notch all the way to the balloon is actually a little beefier too. So you can definitely feel the push better, but the flexibility of the balloon, the scaffold, and the tip are still the same. So you'll definitely feel the difference. On the data, just one comment on the data. You know, that's the overall data for the Absorb 3 trial, which met its primary endpoint for non-inferiority compared to Xience. And the increase, the slightly higher rate of scaffold thrombosis compared to Xience. And as you know, Xience always has a lower thrombosis rate than any stent in almost every head-to-head trial. But in this trial, since Absorb was slightly over 1%, the FDA wanted us to look more closely at that. And as you know, most of those cases were happening in very small vessels, which we're not recommending for treatment.
And this is exactly what you said.
Right.
So very, very important. So all the difference in scaffold thrombosis or device thrombosis occurred in the vessel less than 2.5, means 2.25. And so once you go to a vessel more than 2.5, it's exactly identical in both.
Right.
And this is a very important take-home message, is that a smaller vessel of less than 2.5, this device should not be used, because you have a very great the metal DES. So there is no reason for you to use it. So it's only the device for more than 2.5 millimeter vessel.
Exactly.
Very clear. Both scaffold thrombosis as well as the target lesion failure, it's all related to the small vessel, and that translated into the overall outcome, because this made about 25-30% of the total patient population. And of course we know, because of the larger the strut of 154 micron, and that takes more time to dissolve or require a little longer antiplatelet therapy. But more importantly, it's a little rigid, the struts of the scaffold, so require high pressure to really expand. And recent data actually have come is the asymmetry. Anytime we expand the stent, it's asymmetrical. They did the analysis from Absorb 2 that asymmetry expansion does take place both for the metal DES and Absorb as well as for the Absorb, but clearly the little more asymmetry occurs with the BVS unless you have done a real post dilatation, and maybe that probably contributed part of the higher scaffold thrombosis in early stages. And clearly the meta-analysis of many of the studies actually have shown, yes, overall higher scaffold thrombosis, but lower actually mortality in the trial. And the now recent network meta-analysis puts it together same way, that for stent thrombosis, while it's a beneficial, no difference in MACE, beneficial in lower mortality, but compared to other comparators that BVS does have on the data, so far this is all before our learning phase of the BVS specific protocol, that higher scaffold thrombosis, and this is from 147 the trials, the data. So now clearly more important also is now recent, remember the GHOST EU original data that higher scaffold thrombosis, but now if you have matched cases from Xience V and GHOST EU, which is the latest publication, 1 year outcome, as you can see here, device oriented related cardiac events. So it's actually in Absorb being 5.8, 7.6 in the Xience, the cardiovascular death 0.7, 1.9. This is actually very interesting. Yes, scaffold thrombosis was non-statistically higher, but overall how we are seeing consistently the meta-analysis and the comparative match comparison, that we are finding a lower death rate with the scaffold.
Right. Not sure how we can explain that actually, because we don't expect a difference in mortality. So it's probably a play of chance. But I think what's important about this matching is that as we look at Absorb and we look at outcomes, it's very important to properly match these complex real-world patients with the same kinds of patients with current-day drug-eluting stents like Xience. And when you do that, such as Capodanno and Tamburino have done with the GHOST group, you see that the outcomes are very, very similar. And we'll be able to do what's exciting now, Samin, is we'll now be able to do this in the U.S.
Yes.
You know, there'll be a post-approval study in the United States, and we'll be able to collect the real-world data. You're obviously a leader here in this lab in doing this, and this case will demonstrate what you can do in the real world, which will match a lot of those cases from the GHOST registry.
Absolutely, absolutely. and this basically is that the comparative. And of course, I mentioned the asymmetry expansion. So, clearly little more forgiving with the metal, but once you have asymmetric expansion of the absorb associated with higher device related outcomes, and so clearly the whole issue remains about this scaffold thrombosis, and this occurs early. And more importantly, what we learned is that if you change the protocol, that you can decrease your the using BVS specific protocol from 3% to 1%, and this is the most important. So, we say, well, maybe, may not be, but this is clearly the multi-center from Europe that they went with the clear-cut protocols, which is pre-dilatation with a non-compliant balloon, BVS implantation only after full lesion expansion. If did not, then you don't put a BVS. BVS implant at 12 atmosphere and post dilate with a 0.25 to 0.5 at 16 to 20 atmosphere. I think nutshell, these are the 4 steps which we will talk once again that really decrease the scaffold thrombosis, better optimization, hopefully less asymmetry, and better outcome.
Yes, absolutely. So to simplify it, there's only 2 things you've got to do to really change the outcomes for Absorb and totally change the safety profile. One is properly size the vessel, make sure it's at least 2.5, and the second is just make sure, using whatever techniques you use, and we'll obviously going to go over those, to make sure the final expansion is good. So proper vessel sizing and full final expansion of the scaffold, either with aggressive prep up front, pre-dilatation, or with high pressure NC balloon post-dilatation to get full expansion. Those 2 things, and that's dramatically changed the outcomes. And it took us a few years to learn this in Europe. I mean, these are the smartest and best operators outside the U.S., and now we know. So the U.S. is going to be in so much better shape at this point in terms of the launch of this therapy. We're really excited about the U.S. actually redefining Absorb around the world by what you're going to be doing here.
I mean, clearly that what we learned from all these is the one we are going to use it, and this actually basically we talked about it, full lesion coverage. Your lesion should be open to bring down to less than 30%, then scaffold for the limited expansion, don't go beyond 0.5, and routine post dilatation at high pressure and use the imaging. And so this actually is the same thing which have been translated by the FDA, which clearly puts these together, that in cases that you have to assess the vessels and avoid into the smaller vessels. If you need to do vessel of 2.5 or less, you do a imaging, make sure the vessel is at least 2.5 lumen, as Chuck mentioned earlier, and avoid the absorb stent in vessel which were less than 2.5. I think this is FDA was very clear to make that statement. Reason is, it's not that there is no device for less than 2.5. We have a great metal DES.
Right.
So there is no reason for us to compromise in any way in our overall care for our patient. So use your regular metal, the DES, and this actually has been pointed out in our discussion. The key is also that don't go beyond 2.5 millimeter, and that is the key. So studies have shown that once you go more than 0.5, then you really can cause the breakage of the scaffold. What happens, Chuck?
It's pretty uncommon. I mean, we just don't see it anymore because everybody's erring on the other side to sort of oversize the scaffold a little bit for the vessel size. The package insert says 0.5 millimeters is your maximum limit for expansion, but we know in real world practice from lots and lots of experience outside the U.S. that in a constrained artery where the scaffold's actually constrained, you can take the non-compliant balloon up to 0.7 millimeters over the diameter if you need to get full expansion. Not recommended, of course, that's the label, but if you need to, don't be afraid to do that because full expansion is more important than leaving an underexpanded scaffold. And other than that, Samin, we're trying people not to feel that they have to be too ginger with this. This is a stent.
Yes.
It's got the same radial strength, the same inherent radial stiffness, the same recoil, the same properties as a metallic stent. So go at it. Don't be afraid. Treat it like a stent and make sure you just get it fully expanded.
And that is the key. Should not be left under dilated. If you have to go to 0.75, you need to just open it.
Right.
I mean, that's the recommended and key. Who are the ideal candidate? People ask me because we have very big health system. We are creating the protocol within our system. I would say ideal cases, what we learn now, of course, things will change. Proximal to mid lesion in the vessel size of 2.75 to 3.75, visual, which we know that QCA usually is about 0.25 lower, lesion length up to 30 to 40, so that you have just maybe one overlap. In younger patient, I think real benefit is in the younger patient or in the acute coronary syndrome, and of course the ISR, the trials are ongoing, but some patients where we have failed everything, clearly that this could be the device to use. Not recommended, but this is something which we need to look into it based on the ongoing trial. So clearly, as we mentioned, imaging is very important, particularly early cases, avoid in the very calcific case. And the question people ask, what is the volume? I think taken all these together, 10 to 20% of the PCI volume is the good target. So that will really do a justice to the technique, and we continue to have a better outcome for these patients.
Chuck, you want to comment on the number 5 point there, the ACS patients? This
No.
at least theoretically appeals. We've seen almost 200 patients in Trophy,
Yes.
but for the STEMI subset, this appears very appealing.
Yes, I think so. Now, of course, it's off-label for all stents in the United States, but that's how you treat patients. Most of what you do is off-label, so we can't recommend it. Since I'm now working for the company and not like you guys being independent, I can't officially recommend it, but I can tell you that a lot of cases are being done in STEMI. It seems to be ideal because the lesions are in younger patients in general, more proximal location, softer, and as you know, the Absorb scaffold struts are twice as wide as a Xiant strut, so you get twice the surface area coverage, so you can trap potentially more thrombus and possibly reduce the risk of distal embolization.
Excellent.
These are all forward-looking statements about what may be happening with STEMI with Absorb, but we do have a randomized trial, as you mentioned already, in almost 200 patients, head-to-head versus Xiants, which shows that the OCT healing at 6 months is actually superior for Absorb compared to Xiants. So all is pointing in the right direction for, I know, your passion, Samir, which is STEMI.
Yes.
Absolutely. Samin, excellent review of the cases. Anu, is it a 175?
Yeah, 175 bar.
So aggressive, you want to really prep it as nicely as you can.
Yes, that is the plan. And actually what happened is, our goal is that after the rota, we'll put our run through wire and do the OCT, and we still think that we need to go to a bigger bar. We have 7 French guides.
Right.
So we definitely have some room into it.
So the reason possibly to go with, let's say, a 2.0 bar would be because you want to optimize it absolutely before placing BVS.
And as we also know that rotational atherectomy, it doesn't matter that you are going to really debulk, you are cutting part of that calcium, so
Right.
subsequent balloon dilatation will take care.
Great. Chuck, when can we expect a thinner BVS strut?
Well, we're hoping we'll be able to bring this next generation out in Europe by CE mark by the end of 2017, early 2018, and then hopefully in the U.S. a few years after that. It always takes longer in the U.S.
Is that down to 100 microns already?
Yeah, it'll be in that range of 100 microns for the small diameter and slightly higher for the larger diameter scaffolds.
And when can we expect more lengths and diameters?
With the launch of the next gen. So when the next gen comes out, you'll have a much more complete
But you have to dilate first.
set of sizes,
the
much
OCT.
bigger, wider matrix with more sizes, more like you have with DES.
Excellent.
Now, AK, do you feel we need to go to bigger, or because you had a lot of resistance in
No,
burring this?
I think we'll be fine.
Will be fine.
We just dilate it and then do the OCT.
Perfect.
Then we wire the side branch.
Chuck, do you think BVS has taken us a step closer to preventative interventions?
So ask that again.
The preventive prophylactic
for,
PCI,
vulnerable
Yeah.
plaque.
vulnerable
Are
plaque.
we a step closer to that?
Yep.
Yeah, I think it brings us one step further because it's not a permanent implant, right?
Right.
And
Yeah.
if you're going to treat a vulnerable plaque with an implant, you don't want it to be a permanent implant for what's really a temporary problem. And that's something I like to stress also for obstructive lesions, that obstructive lesions that cause ischemia are a temporary problem.
Right.
You don't need a permanent implant for a temporary problem. We didn't need it with balloon angioplasty. We never would have abandoned
Take a picture.
balloon angioplasty if we hadn't had abrupt closure and restenosis, right? Because no one wants a permanent implant necessarily. So for vulnerable plaque or non-obstructive lesions, there are 2 studies going on outside the U.S. now that will look at that. One by the SCAR group in Sweden called Prospect Absorb, and then one in South Korea headed up by the team there, and that's called Prevent. So 2 that are looking at that very question right now.
Fantastic.
And particularly same, that can you do the plaque sealing, and you know the earlier with the metal did not work out, but clearly the totally different issue in this setting.
So this is the run-through wire there now?
Yes.
Yeah.
Okay. Chuck, we had a wonderful conversation during the Solasi meeting in Rio recently, where you were telling me how the rollout is happening around the country.
Yes, it's been exciting. You know, we got FDA approval for Absorb on July 5th, so the day right after the holiday, Independence Day, and it's been a great experience so far. The first week opened up about 10 or 15 sites, and now we're upwards of 40 or 50 hospitals in the U.S. that are going to have product to be rolling out, which is very different, as you know, from the launch of any other drug-eluting stent. It's a very phased launch with careful training. It's a very responsible launch, in my opinion. And as you know, Samir, my job is not only CMO, but I'm also the Chief Safety Officer. So I watch everything that's happening. And as you mentioned in your introduction, it's something that I am very, very conscious of and feel very responsible for. So,
Chuck, we hold you in enormous respect for those absolute characteristics. You're completely right. What amazed me listening to you in our meeting recently was that you had to train an army of your reps who are going and helping the physicians in the cath lab.
Yes, absolutely. So the training consists of an online module, which takes about a half hour to do, that goes over the technology and implantation techniques. The second part is an in-person sort of verification that the module was done and that there aren't any questions. The third part is what you mentioned. There's a sales representative in the first 3 to 5 cases for every operator when they start using Absorb. And the reason the sales reps are so good now is we put them through what we call Absorb University. And I guess you can say I'm the dean of Absorb University or something, but they really know their stuff. It's like the good old days of ACS and Guidant and Abbott Vascular early on when stent technology was evolving, and the reps really were a very important part of the procedure.
Is that something you and the folks at Abbott Vascular figured it out, or the FDA requested you to do
Automatic working?
We recommended it at panel.
Fantastic, fantastic. Do you once in a while see your family?
Every once in a while, but no more than you, I'm sure.
Look, it's going to be a tough, I think, a year, 18 months, but I'm sure it's going to benefit thousands and thousands of patients with this absolutely transformational technology.
No, actually, I want to say really credit to, of course, Chuck and the Abbott organization. This is the device which they have been working for over a decade.
Right.
Probably have spent $1 billion, but yet after FDA approval didn't get greedy and let's make it available in 1,000+ labs. Right. So very cautious, clearly do step by step. So that is the right thing to do.
Right.
And we know that the device itself will take its shape, whether it will be a 5% or 20% or 25%. But it's a basic background teach is the really which Abbott is really emphasizing.
But congrats to you for helping out in this. I mean, this is peer-to-peer teaching we're talking about right now. You guys are going to lead the way in your experience, and that through these types of live webcasts and through all the different meetings that will come up, well, you'll be speaking about the technology. You're going to learn and you're going to teach others. And congratulations to you for doing this today. I think this is a fantastic way to spread the knowledge and also the experience, and we're all learning here, right, as we go through this. So
and I'm sure this will be seen by more than 6 or even 10,000. Few of our episodes have been 10,000. I actually want to complete this statement of the first part of the presentation, and you see the angiogram is good. Anu is getting ready with the OCT, and the statement which I really liked, although it was in the CCI by our group, that basically that real world experience with BVS, trading early sacrifice for a brighter future.
Yes.
It's a very, very good. But we are talking about even not early sacrifice if you do it correctly.
Yes.
So that is the key. So clearly that the brighter future, that is what is intended for. I mean, that's what the whole purpose was. So while we are getting ready, quickly I go with the data of the IVUS and OCT. And I think, but nanosecond. So basically one of them is came out in JAMA late last year, IVUS XPL randomized clinical trial in the long Zions stent, everolimus eluting stent, and they did IVUS versus angiography guidance, and basically showed that IVUS guidance associated with lower MACE and of course largely driven by lower TLR. There was no difference in stent thrombosis or so, but just to say, one of the largest trial of 1400 patients, IVUS guidance decreased the overall MACE rate largely by decreasing the TLR. We know some data have been in the lower stent thrombosis also, but clearly this was the good the snapshot. Also more importantly, that if you really do IVUS guided criteria, you fulfill the criteria, your overall, while in the IVUS group it was 2.9%, your event rate at 1 year will become 1.5 if you follow all the IVUS criteria. Very, very important. So within in the 2.9, you follow the IVUS criteria, became 1.5, otherwise it was 4.6. So this clearly one of the randomized clinical trial of the intravascular imaging, which I had shown the benefit. Of course, now we have a very nice 7 randomized clinical trial of the total 3000 plus patients in the era of the drug-eluting stent, and these are the various randomized trials, their case numbers and so on and so forth, and the lesion characteristics. Just 1 second quickly, that overall showing the MACE rate is lower with the IVUS guidance with the 6.5 to 10.3, and of course this is all associated with the lower myocardial infarction and lower TLR and stent thrombosis, and this is overall meta-analysis shown clearly in this recent very nice review of these cases. So seems to be that overall IVUS is helpful in these cases. Yeah. Okay. Now Anu is ready with the OCT, and this is where it comes down to the next presentation. So now they are ready with the OCT here.
It's showing up.
Yeah, we see it very nicely, Anu.
Good.
Tell us what you are seeing there.
Okay, let it to come back.
Huh?
What to do the no, don't go to the left wing. Okay.
Chuck,
Sometime
a
it does
few
not.
questions have come in for you, which I'll take after we do the OCT analysis.
Okay.
I can say what's happening. What are we seeing in the OCT now?
So, okay, see
Centric.
the okay. Let's go to the calcium.
Yeah.
Looks like
Sorry.
160 degree, right? 2 quadrants of calcium.
Right, right.
Not complete. You see that? That's calcium.
Well, I'm sure it was
Yeah,
much
yeah.
more before the rotablation, but
I mean, probably not a lot. So this is a nice. See that?
It's
A
Chuck,
nice
purely
interpreter.
from calcification point of view, acceptable for OCT?
Yep.
I mean, yeah, for
Yep.
BVS it is.
For BVS it is,
Yeah,
and
I'm
there's
sorry,
a little
yeah.
dissection, which is perfect. It means you've done some good
And I think it looks like
angioplasty.
the lumen is nicely prepped, and just give us a diameter just at the level of the septal now, and the diag. You see the 2 branches, nice.
Yeah.
Give the filter wire.
My guess would be a 3.5. Let's 3.12. Okay.
Good.
Okay, go back to the ML. Why you don't see the diameter at the side?
Go a little further down the vessels. No, 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 no. Yes. Go further down. We want to go after the septal. That's where the lesion was.
Mm-hmm.
A little
Little
more
more
distal.
back up.
Little more distal. More distal.
Keep. No, back up, yeah.
Right there.
What happened to the screen?
Pablo, why can't you fix this?
Yeah. What is the vessel size here? No, go further up.
No, diameter we are asking for.
Yeah.
Reference vessel diameter. You are going too distal.
No. Go back up. Keep going back up. Yeah, this level. I think this is where we should concentrate.
Yep. I think I would size it by the proximal reference vessel.
No, you went too much outside.
Huh?
What 2.5? It's getting you 3 point.
Probably 3.0.
Boy,
Okay, look
visually
at
it
your
doesn't
B.
look good.
B is 3.8. You went
Length.
too far.
think length.
Cut it.
That's a length.
No, it's not length. Look at the B.
You want decimal?
No, no.
So lumen is 2.5 and 2.7.
Wow.
Okay.
That's
put the
surprising
diagonal.
actually, because
Yeah.
visually it doesn't look
Visually
that
looks
small at
like
all.
3.5.
It does. I know. That's surprising.
But that could be all.
Usually the other way around. Huh?
Yep.
But anyway, yeah.
So
And
what's the
What is the
proximal?
proximal is how much?
I
Yeah,
would
this
use
one?
the proximal reference as your.
Yeah, there.
352, that seems right.
Yeah, there you
Yeah.
go.
Chuck,
would
so
have-
the question, Chuck, for you here is
Looks like
that,
a 4.0.
and Samin
no
had
lesion
kind of
there.
mentioned it in his procedural recommendations. The specific question has come for you is that even if angiographically I am
You
convinced
put a 3.0.
for the first 10
Yeah.
cases, is it
3.028.
a good
that's all.
practice to use OCT?
Before that, let's do the 2.5.
Or IVUS, if you don't have OCT available, IVUS. And of course,
But
I
the
will ask
question-
Chuck to answer that question.
Right,
Yeah.
this question specific was asked for
OCT
OCT, I
only.
believe
Oh.
they have OCT.
Okay.
Chuck, what would be your answer? That angiographically they feel comfortable, but for the first 10 cases, if OCT is available, should they use it?
Yes, yeah, we're recommending
Wonderful.
that because what happens is you retrain your eye by doing routine imaging. I mean, look at this case here. We all thought it was 3.5 millimeters.
We actually have a 3.528 ready. BVS.
Right, and and it turns out it's really going to be closer to a 3.0. The proximal edge will need to be probably optimized with POT to make sure we've got apposition proximally because this LAD really tapers a lot. But this shows you what imaging can
2.515.
teach you as you go forward, and it'll retrain the eye so that in the future you really won't have to use it in as many cases as you do in the beginning. But it's a
Excellent.
great learning experience in the early going.
Chuck, the similar situation of side wire guide wire jailing with BVS just like DES. Any special precautions you need to take?
Just like with DES. You can
Perfect.
trap the wire, you can leave it in to protect the branch, you take it out whenever you want.
Perfect.
You can also rewire the the scaffold
Through the struts.
through the struts to re-access the diagonal and do whatever you need to there. You can dilate the ostium of the branch up to 2.5 millimeters,
Yep.
so a 2.5 millimeter balloon without disrupting the scaffold.
Excellent.
To go a little
But
further.
they recommend kissing.
Chuck, at some stage you think the visibility is going to improve?
Probably not.
Yeah, because
Not yet.
with the thin struts it may even be, so the markers have to
No,
be
they are
relied
not.
on
See that?
compulsively,
Okay.
Yes,
particularly when you are overlapping, no?
yes.
Down.
It's
What do you
just
want? This is
a whole
2.5,
nother
right?
technological
2.5.
issue to
2.5,
try
18
to
then.
Yeah.
18
blend
may come
in
up
any
to the ostium, no?
iodinated
2.5.
material to make it visible. And I think you guys are going to get very good at doing this without having to see the scaffold. It'll become routine for you.
Excellent.
Yep.
A
18 will
nice
be good.
little angioplasty.
Yep. 18 will be good. So while we are getting the stent in the side, let me just complete my few more slides of this field of combining IVUS, OCT or just angiogram. So this is what one of the question was. My eyes are good. Does it mean that we have equal outcome? Actually, one of them was we have from A Lumen 1 where OCT was done along with FFR, and that what they did in this study of about 400 plus patients, that you change the strategy based on the OCT. So clearly that FFR said yes to do a PCI, but OCT changed in almost in 40 to 70% of cases for the better outcome. So clearly was that yes, by using the OCT you do change some of the outcome in these cases. So what they did, second part was the iLumen 2, which they took the iLumen and they took which is the OCT part, and then took the Adopt DES, which is the trial of the platelet the platelet activation and overall outcome after the DES by Greg Stone, and actually show basically that what is the difference in the matched cases of the OCT and IVUS. It turns out to be that overall the stent expansion so was not different, but OCT is more specific for your malapposition, any stent protrusion, and some minor dissection. So yes, overall stent expansion was identical, but the issues of your minor, like say subtle, the parameters of your stent related or lesion related were better seen by OCT, whether it will translate into outcome, which we do not know.
Right.
And this actually just shows that dissection, plaque protrusion, and of course expansion is little better. Our final answer will be this study Illumin 3 by Ziad Ali, and this is comparing OCT, IVUS and angiography in 150 patients each, and they have multiple runs, and OCT is done in all cases. One is the OCT guidance, other they just took the OCT will be blinded. So idea there is to say that whether your angiogram is good or you need to do a OCT.
Give some adenosine.
Yeah. That you need to do a OCT or IVUS, and particularly will become more important once we are using the Absorb. So this trial has been completed, will be presented in TCT 2016. So we have some idea about another study which compare the OCT and IVUS, the opinion which was presented in Euro PCR 2 months ago, and basically by the 800 patient using the OCT and IVUS. Overall, there was no difference in the primary endpoint of OCT versus IVUS, also the stent expansion, all were identical. So clearly, with this field is progressing, and where we will be, we do not know, but definitely there is a lot being done to combine the imaging to get a better outcome of our interventions.
I would want this stent to go a little further, but having difficulty in making progress.
Yeah.
So even in
Okay,
2016, we have difficulty in advancing metallic stents.
Yeah, well, I mean, this was a very angulated calcific
yeah.
vessel,
No, look,
and I don't think we fully dilated the lower
Right,
further
part of
segment.
We did.
Yeah. So if it is required, we can go back with the balloon again,
And dilate, yeah.
and let's ask the deep breath and
Take a deep breath, sir. I don't think it's
put the wire a little more.
the wire.
Good, sir.
The wire went more and he went into tachycardia.
No.
You want to come out?
And Anu, this is a 2.5 stent.
Good. It's a 2.518.
Okay, you're going to dilate more or there?
See that how it is angulated.
Now, if you want to do angle, we have to go back with the balloon and dilate a little more
Yeah.
in that
I
area.
think it's a good idea.
Yep.
Then the lower branch you will lose.
Yeah, but that's
I'm
no,
telling
we
you
still have
now.
a gap between there, right?
Dissect everything.
Good. We have the, yeah. You want to put another wire there, run through? Give us one more run through wire.
No, we can try the same one.
No,
So
they
Chuck,
don't
so
go down.
far as the lesion has been prepared
we don't want
well,
it. We don't
so
want it.
far as imaging has
want
been
guideline?
intelligently deployed, does it matter
balloon.
whether you are
Synergy
going
would have made
femoral or transradial?
No, it works just as well either way. The key is just to get good guide support.
Right.
Good coaxial alignment, good selection of the guide shape, so you get coaxial and you get good backup, just like you would for any case. And you can see here the guide catheter support is actually really important for the diagonal.
Yes.
Yeah.
You know, even just to get the metallic stent across. So this is fundamental angioplasty. Your life will be simpler, your procedures will go faster if you think about each of these things, whether you're doing metallic stenting or doing Absorb, of course.
Between IVUS and OCT, which would be a better modality for BVS?
OCT, in terms of the detail of being able to see the struts and look at apposition of struts and expansion, but actually IVUS is probably just as good when you're talking about just looking at expansion, okay,
balloon is
whether
having
the struts
problem, forget the stent.
and the lesion is fully expanded. IVUS is, I think, just as good as OCT.
Right.
But for looking at the individual struts and looking for apposition, OCT would be more, would be more accurate, as you saw in the data that Dr. Sharma showed you.
Which would be more accurate for sizing?
They're both good for sizing.
Okay.
Most people say OCT is the gold standard for sizing.
Did this statement which you just make also factor in your acquisition of St. Jude?
Well, it was a small, not a small
Component.
part of it, but obviously not the biggest part of it. Since St. Jude's, the majority of their business is in the CRM
Yeah,
and in
vast.
valves, so that was the key for the diversification of our business.
Very,
But-
very diverse portfolio they have, no?
Right, but many other technologies that will really complement what we're doing in vascular today in the structural heart area, as you know, as well as in imaging, as you're seeing here in FFR.
They've recently had approval of another pressure wire.
I think that's coming up.
Right.
Yes.
Excellent.
Yeah, and actually that is the leader in our the pressure wire at present.
Exactly.
The St. Jude's, because most of the data, although now some others, both the Assist have come up with their device, and now Boston Scientific all have their own limitations and plus and minus points, but the maximum data we still have from the pressure wire, FFR wire of the St. Jude's, all the FAME trials.
Chuck, internationally, where have you been the happiest about the use of BVS?
Primarily in countries that have reimbursement, as you can imagine,
Yeah.
because it's slightly more expensive than a current day drug-eluting stent because it isn't a new category.
On the other hand, I have even each time I speak to Ashok Seth, there's been a fair use in India.
Yes, India would be the exception to what I just said because obviously there's no reimbursement there, but the technology is highly valued, and as you know, many patients are paying for the technology because they want it
Leave it.
as opposed to a metallic stent. So India is currently, I think, still either number 3 or number 4 leading country in the world in terms of absorb implants,
Wonderful.
No?
and has been that way since launch in
That's
India.
where we were
Yep.
before.
So we are able to get in, going up.
I think it looks pretty good now.
Yeah. So usually we deploy our metal DS about 16 atmosphere. In the earlier generations used to be that edge
Down.
dissections, but the newer balloons
3
are
or 28
less
ready?
compliant.
So we all
and
are
we go with the 16 atmosphere. But compared to the Absorb, we actually recommending that deploy at 12 because you're post dilating every case. While for metal DS post dilatation, in my opinion, we do it only in about 50% of cases.
Go.
Good.
Little dissection distally.
Yeah. You need to get a balloon. 2.5, 15 balloon first.
2.
Huh?
2.
The new one, compliant. Give me.
This is exactly what we
Give a-
predicted. When you
give a
go back
20,
and do
yeah.
the angle.
2 or 20 compliant balloon.
No.
Chuck, which part of the world is demonstrating the highest surge in PCI volumes?
The highest percentage of PCI volumes for
Right.
absorb?
No,
overall.
just overall. Just overall, I mean, I recently, when I looked at it, the traditional answer seemed to be China and India,
Right.
but I was also surprised on how big the expansion is in parts of the Middle East and
Yes. Yes, so it's really the emerging markets. So Eastern Europe, including Russia,
right.
Middle East, and then China and India would be leading the way.
Excellent.
But Southeast Asia continues to grow. It's pretty interesting, even in Indonesia
Right.
and Malaysia.
Your high pressure killed it.
No high pressure.
Deployment at 60.
How is South America coming up?
Brazil has approval
Yes.
for absorb now, and in terms of overall PCI volume, Latin America continues to
0.28.
grow as well, but it's a much smaller market.
Right.
A lot of reasons have to do with reimbursement
the edge.
and just access to the technologies.
Right.
Okay.
So basically what we are doing is that we are putting a 2 or 20 compliant balloon and just try to tack up at a moderate pressure of 8 to 10 atmosphere. That show the last picture. Now that level, it has to be the edge dissection of the balloon even.
Yeah.
Because we didn't take a picture after the balloon dilatation, because we needed to go to high pressure with the balloon. So to me, I think it's related with that.
Right.
Now, if it requires something, that we may need to go with the 2.25
Stent
designs.
here, yeah. So Chuck, here is a breakdown of the
2.25.
85 cases which we have done the live cases.
done.
Out of that,
I'm done.
22 were left mains, 31 bifurcations, and 18 CTOs.
Wow. That's a great mix.
Yeah, it's truly the 3 substrates of complex PCI,
Yep.
and there it looks much better there.
You want to try 2.25?
Yes. And of course, the webcast for our viewers is you have 3 options. You can go on YouTube, you can access
2.25
YouTube
12.
through our iPhone app, or go to the standard old
2.25 12.
CCC live webcast site.
Yes. So we'll try the 2.25, the stent through the 2.5. So the distal edge. I think the lesion was longer, and we put only the 18 because there was a 2-segment lesion, and it's created a little dissection at the level of that branch. Because the key is the same. We want to prepare it well. I mean, we want to take care of that because we try to avoid going through the struts. So now, even if you have to go through the struts, check what is the recommendation that you can dilate the struts with which kind of size of balloon. Let's say you put a 3.5 scaffold in the mid LED, proximal mid LED. You now need to go to the diagonal.
Right.
So what size you can use to open the struts?
Up to 2.5.
Okay.
2.5 millimeters is fine. You will not disrupt the scaffold. If you have to, you could go with a 3.0,
We go balloon. We
but
need balloon.
not preferred.
Okay.
Go with this
Understood.
wire, no?
Okay. Yeah, you can go with this wire. Yeah, put the second wire. So what we are going to do is use the run-through wire of the LED and use a buddy wire to get the support, because very angulated. The diagonal which we knew right from the beginning. Good. That's okay. Right.
Going into some small twig. Okay.
There you go.
got
Good.
it, got it.
Okay.
Good job.
Now, some deep breath, sir. Give a deep breath.
Chuck,
Another
how
question we can get-
long do you think
get
it
the
will take
guideline.
for a complete nationwide launch of BVS?
We plan to launch upwards of about 600 hospitals by the end of the year, by this time next year, really, the end of the first
to leave.
12 months. So it's, you know, it's a
Guideline.
very phased
Got the guideline.
launch. So about 300 hospitals in the first 6 months and another 300 in the back half of the year.
And so just around the time you have the 600 odd, hopefully the next 2.0 BVS should be available. Around that time, just around that time. So that
You
would
guys
put-
are always so optimistic.
No.
Well,
Should we
hopefully
dilate
with
the
with
distal
Dr. Caliph there,
No?
things will be
Should we
a
get
lot
the
faster
distal?
at the FDA.
Yeah.
I don't know,
Just
Rob
ledge.
has a lot of
Get
other
2.5?
things on his
Yes,
plate,
yes.
you know.
Very tough
You have
job.
the 2.5 balloon, right? Maybe we dilate the
No,
distal.
but we'll go with the
So
guideline.
here, Chuck, we were demonstrating,
Photos,
and
yeah.
all the focus was on BVS
Maybe
and
we go on the run through.
challenges with the diagonal.
Yeah. Well, we knew about this diagonal. I mean, that's
Right.
why the whole purpose
Yep.
was to make a complex case. And we even discussed about that should we even think about the absorb of the diagonal, knowing that there is still sparing of the ostium. So, but because of the same virtue, which we are, you know, the issues which we are seeing at present, we knew that will be a very difficult tracking because as
The
such.
balloon?
Now bring that balloon. 2.5 balloon. We have here quantum apex 2.5. So now what we have done
You're
is
going to
this
dilate that better and then
yeah,
go back to
exactly
the 2 to 5.
distance and we have the guideliner. So these cases, what has we learned that guideliner really helps you to deliver with a less push and pull and causing the deep throating of the guide and guide induced issues. So we have very low threshold. Even you put both the wires to the guideliner, that is what we have done. We are advanced. We need to advance the guideliner a little more. So we are putting the balloon first, and you see.
But I changed now. We have gone on the run through. Earlier was fielder, and if you
Right.
see,
Little
fielder
more
actually.
support.
Yeah. Now we'll see. how-
Chuck, the guideliner can be
Down,
a
down.
pretty useful device for deploying BVS too.
Sure, just like with metallic stents.
Right,
They're
better
just,
support.
Good.
Go.
Yeah.
Yep, there's just a couple of restrictions. So the 6 French guideliners, so the 5 and 6, you can only use the 2.5 and 3.0 millimeter scaffold
Good.
in that guideliner. and you need to insert the scaffold into the guide liner, past the notch where it goes into the guide liner lumen, outside the body before you introduce it, because it's a little snug. If you put the guide liner in first and then try to deliver absorb, then it'll get caught on the entry point to the guide liner. So the key is to load it, preload the guide liner with the 2.5 or 3.0 absorb, and then introduce the whole system together.
So what do you do if you have a 3.5?
You can't use the 6 French guide liner.
Then 7 French.
7 French base then. Okay.
Give me.
All extremely useful tips, Chuck. I'm glad we have you back there.
Yes.
I think you've got plenty of expertise in the room
Right.
here,
Yeah, but
Samir. But it's great to be able to be a part of the team.
But you're right.
Absolutely.
I mean, I think you need a special technique for go through the 6 French. As Chuck mentioned, that you load up with the BVS to begin with, because otherwise it does not come out through the 6 French. We have tried it during our Absorb trial.
Right.
So this we have not tried with the GT1.
Right.
But the Absorb,
same.
yes.
It's the same.
It's the
Same
same.
with GT1.
So same. So you need a 7 French. Okay.
Okay, if you see here, one of the important point where I think if you already have a proximal stent, how would you advance your guide liner? And if you see, this is where you go distal, very important, and once you dilate it, slowly over the balloon, you just advance the guide liner so that you are not disrupting the just placed stent. This is especially important if you are doing RCA. If a proximal for some reason the proximal RCA stent has been placed in a heavily calcific vessel, and now you have a distal edge dissection and nothing is going, you need a guide liner. This is what you do. You go distal, dilate, and the balloon has to be same 1 to 1. Don't go with a small balloon, everything will come out. The guide liner will not get sucked in.
It's a really nice technique.
It's still not going, huh?
The turn
Still
is-
a little struggle, huh?
don't want to get too aggressive here, right? Let me just see a little bit more.
Wow.
Only other
Guide
thing now.
liner's way down now.
Yeah.
You want to really do it, then you have to go and suck it more.
Okay. Get the balloon again.
You change to the other one, it will fly.
Huh? We need a new balloon.
I'm saying
new
the
bal-
stent. No?
No, not yet. Okay. So we are going to go get the guide liner a little further, which is okay.
Get the same balloon?
Chuck,
Let me get
has Abbott Vascular been proactive in helping the reimbursement issues?
Yes, you mean outside the U.S.?
Right, and
Yes.
even in the US?
Yes. But, not so much for drug-eluting stents. Absorb currently is in the category of DES, even though it's a very unique and different technology. We'll need to show superiority, right, in an endpoint that would impact the cost of care.
Right.
So the
Don't
future
go high.
data that will be coming out from Absorb 4, pooled with Absorb 3, is intended to show superiority of Absorb over Xience at 5 years of follow-up, because that's when the scaffold's completely resorbed, and that's when we would expect the outcomes.
For the overall cohort or even for subsets?
For the overall cohort.
Excellent.
Deep breath, sir.
So, it's possible if we show superiority at 5 years
Deflating.
on
I'm
long-term
deflating.
outcomes, that then we could go back and apply for a differential, DRG or reimbursement.
Right.
But I can tell you the Abbott has done a great job for the mitral clip reimbursement, because every case in the past we are losing about $15,000-$20,000, and now with the edge of next month with the added reimbursement, it's really so, and that is why while the tower has taken off and clip has not taken off.
Right,
So
right.
This,
Go
Yes.
up again.
yeah.
Well, the hospitals were great partners in that, because the hospitals had to submit their cost data.
Yes.
And all that data has gone to CMS. And
Yes.
probably by
Deflate.
October of this year, MitraClip DRG will be upgraded,
Yes.
we anticipate.
Chuck, how has the release and expansion of
Like we go
the
on the
mitral
field
clip
of
programs going on in the US?
Yes, it's been going very, very, very well.
How
Samir.
many centers in the country?
It's about 200 and, I think now up to about 235 hospitals.
Wonderful.
So we have dilated now. I think we go in the fielder wire, because this tortuosity you need to, that angle tortuosity, you need a fielder to make that turn. Okay, one more try. If not, you want to get some longer balloon, high pressure. 2.520 high pressure, so the more smooth expansion
stent.
there. Yeah.
Change the stent.
No, okay, which wire has come out?
Oi.
Run through has
Maybe
come
the-
out, that's fine.
No,
Take
no,
it
no,
out.
no, not the run through, I think. Yeah. Leave it there for now.
Good.
Don't do anything.
Okay.
Let's place the stent and then hopefully. Deep breath. That angle is a problem. Not to push too much, right?
Okay. Breathe normally. Good.
Did you change the stent or not yet? We should. It's too much you're doing.
The
for
other
small
question
vessel.
is that,
See, fielder does not go at all.
no, okay,
This was the 225, no?
yeah. Well, actually, now we have the 2.0. Onyx will be available in the market, I think, soon, because that will be the smallest of the DES available. And other one is the, since this is not making the turn, you want to go with the even further thinner strut
You
synergy?
won't consider something like a mini vision or something.
Yeah, or
You get a synergy. 2 to
Less.
5, 12.
on the run through?
Chuck, with
I think
the
run through
focus
better.
being
Okay.
from Abbott Vascular on BVS,
Get me
are
the
there
balloon again.
advancements still
Balloon
in
again?
the Zines family
be.
coming on?
Yes.
Get a new 2.5.
Yes, so the next generation
this
Zeiss will
one
be
off.
coming out in about a year.
2.520,
Anticipated,
much.
just
what do you want?
what our plans are.
right? 2.5
New.
we had.
Get
No,
a new one.
And
2.512, new.
there will be a
High pressure
slight change in the stent design, but a very significant change in the underlying balloon delivery system. Most of deliverability has to do with the underlying balloon delivery system more than the stent, actually,
Right.
from an engineering standpoint. And so, yes, you'll be seeing the next gen Zeiss just continuing to improve deliverability.
Exactly. And so far as BVS technology is concerned, any of the
Yeah.
newer
Open.
oral antiplatelet agents, have they shown any difference than clopidogrel, or makes not much difference?
No difference in the clinical trial outcomes, Samir,
Right.
but there is some thoughts that for patients with complex lesions where you have overlapping scaffolds,
Right.
and certainly in acute coronary syndrome where it's class 1 indication, that we're recommending the more potent direct P2Y12 inhibitors.
Yes.
Open.
Going up.
Oh, you want to wait. You want to try the same stent? Open. It went further down.
Okay. Do the, you want dilated at edge here now a little bit?
No.
Huh?
Okay, go
This one.
here.
Yeah, just a little bit.
Get the same stent.
Yeah.
Okay, I'm taking it out.
So this is a non-compliant balloon you
Yeah,
have there?
yeah. we are
I went to
just
the newer balloon and
little
then see, as the balloon is deflating, I'm advancing the guide liner.
Yeah.
So we got sucked in more.
Must come out. Yeah. But now you have to advance the wire.
Right now, don't touch anything. Get your stent there. Don't pull. Okay, get me the stent.
Chuck, what are your thoughts on shorter durations of DAPT for the newer generation DES?
So it's pretty much along the guidelines, and you saw the updated ACC/HA guidelines are now recommending for stable patients, stable ischemic heart disease, as short as 6 months of DAPT. So the P2Y12 or so the clopidogrel or one of the other agents could be stopped at 6 months in those patients. For patients who have high that are at high bleeding risk, and there are specific criteria for that.
Good.
You could potentially stop as early as 3 months in a patient with stable ischemic heart disease. So the guidelines definitely are moving in the direction of shorter duration. No question about it.
So that is, I mean, the 225 stent back there.
Yeah, same. Same.
Okay.
We went with
so
the.
all it needed
brand.
was more expansion, more
Dilatation,
aggressive with
yeah.
the non-compliant balloon.
That's right.
Yeah, that's nice.
See a little bit.
Good job.
Some die.
Sometimes actually pulling the buddy wire out in
Yeah.
a small vessel like this helps.
Right.
Okay, some die.
But the angle, as Dr. Kenny was saying, it really is related to the angulation
Good.
there.
Okay, good.
Yeah, I think even changing the guide wire may have also contributed there, but host of factors and
I think what made it was we went with the newer 2512 balloon, and you saw as we were deflating the balloon, we just got the guide liner sucked in more.
and
That's the one
Sameer,
that
this
went
was
up.
only supposed to be the side show, huh?
I know.
Good. Wow.
Yeah.
Sometimes that happens.
No,
Yeah,
no.
pull
I
back
mean,
a
I
little bit.
think
It's a great teaching case.
No, we
actually.
knew that. Remember our,
Even
based
before
on
we
our
start-
complexity, we wanted, yeah, good, I'm going up now.
Great. Good. That
Right.
keeps sucked again. Yeah. down.
That we wanted to make a complex case, because otherwise just a usual, it's a, all teachings are there for a regular BVS deployment.
So Chuck, tell us about
What's modeling?
also that if you have a bifurcating situation, you probably are better with more of a snuggle rather than a routine kissing technique.
Yes, and we can talk about that once we get the absorb in.
Right.
But you'll prefer not to use side-by-side kissing balloons for final dilatation
Expansion.
of a scaffold in a bifurcation, right?
And don't worry about side branch now, main vessel only. We got a new run through.
Maybe take a quick picture to make
Yeah.
sure the diagonal's okay.
Yep.
That's the
Okay, ready?
Good.
Nice.
Side branch
Diagonal
is
looks
gone.
great.
yeah.
Yeah, that's
Other
okay.
branch,
Yeah.
which we
Very
knew.
nice work
Yeah, which
by
we,
Dr.
which we
Kenny.
suspected right through that
Yep.
that dinky.
A lot of nice demonstration of tips and tricks
Take the
there
run
on
through. I mean, this
Right.
angulated,
guideliner out.
calcified small vessels.
Okay.
Buddy
Now
wires,
let's go to the
guide
main
liner.
work that we wanted to do.
3028? Yeah.
Good.
So tag alert, this also which we have learned now, that it's a big temperature control. So the where they stored, how they are covered are very important.
So
Because-
Chuck, should we be planning to see a lot of BVS live cases during TCT?
I hope so.
Yeah.
I think you will, because I think people are going to want to see a lot of different
Absolutely.
cases, a wide variety.
Samin, and we plan to show a lot of BVS cases over the next several webcasts.
Absolutely, and we actually have a live relay, 1 hour on November 2nd in the part of the TCT, and in which Dr. Leon asked us to show orbital atherectomy on one side and rotational on other. And of course, we'll see what is appropriate use of the BVS in those cases.
Excellent.
Yeah.
Well, you've been a pioneer with both of them.
Yeah. So that is what they
how
wanted
is-
to
right,
see.
yeah, I think it's a very appropriate,
Yes.
the go with the where the sites have demonstrated expertise and discipline.
Yes. No, you need to go
Nice.
more.
Yeah,
No?
Just about time. Huh? See that?
Okay. Take a picture.
Yeah.
Very important for positioning here.
Go.
Good.
I'm gonna
Looks,
pull back just a little bit. Huh?
So Chuck, explain to me and
pull
to
back,
our
pull back.
audience the relationship of the BVS as it relates to the
Good.
markers.
Okay, go.
So what you see are the balloon markers. The edge of the scaffold is exactly on the balloon marker.
2.
There are markers in the scaffold, platinum markers,
Oh.
2 small markers at the proximal and distal end. And so once the balloon is taken out, what's left are the platinum markers on the scaffold, which are more difficult to see, but not too hard to see when you get off the diaphragm or do stent boost. They're pretty easy to see.
And the expansion has to be gradual.
Gradual.
Yeah, so you can
yes.
see what Dr. Sharma is doing here is gradual inflation, 2 atmospheres every 5 seconds, up to 10 atmospheres. One of the things we try not to do is
Probably can
is
do
to
another
take the
case and
delivery
come
balloon
back.
up too high because it will expand. It's a very semi-compliant balloon. So it will grow in quarter size as early as 12 or 14 atmospheres.
And
So-
you take about a minute, take your time to slowly expand it.
Right.
Yeah, I mean, recommend at least 30-40 seconds for sure.
Look, I can tell you straight away here without seeing the outcomes that it has been the best teaching
what's
point
the-
in this
What
case was the
3.25?
lesion preparation.
3 to
You have the
520 high
adequate
pressure.
lesion preparation.
But proximal is very
Delivering
big, almost
BVS
4.
should not be
Right.
difficult.
3.5.
Yep.
Proximal you have to go 3.5.
Yeah, you're going to want to optimize
No?
that.
Maybe 3.75 approximately. 12.
No, it shows 3.5.
Okay, then 3.5.
Yeah, that's a good point, Samir. So one of the things we didn't point out on the OCT, because we were very much focusing on sizing,
Right.
Ready?
is if you look at the actual lesion site on
Ready?
OCT, that was a very nice prep.
Same.
Yes,
I mean,
exactly.
even at the lesion site, the MLA was over too. So
Wow.
Looks very nice.
Yes.
Diagonal is beautiful.
yeah.
So
yeah,
any
it's really good.
work, Chuck, you think proximally needs to be done?
We are going to post dilate
Yep.
with 2 different balloons.
Got it.
I think we'll go with the 3.0. 3.0 to the distal part and probably 3.
3.5 proximally.
Proximally.
Yep,
Yeah, that's okay.
agreed.
What do you have you opened?
3.25.
You have?
20, yeah.
Okay.
Which is okay, and then
OCT ready? Flush it.
proximally you want 3.75, 12 or
And
8.
you want to go about what 16 to 20 atmospheres? How high would you?
No, 3.5. I think because remember it's a 3.0, so we go with the 3.5, 12 proximally,
Okay.
or 8 even, 8. So
And
that is
you-
just before that bifurcation.
And we plan to do a final check with OCT.
Yes.
Yeah. Now this is the key. Make sure you have your dots.
Chuck,
No doubt,
seems
no doubt.
the right strategy from your point of view.
Absolutely.
Okay.
So what size balloon is this?
This
This
is
is a 3.0.
3.0.
yeah.
Okay, you see the dot there?
Yep.
Sine.
Yep.
Okay, go up SS.
Yep,
Just
we are
at
in
the level
dot.
of the dot.
Yep.
Yeah.
Yep. You're inside it. So you can see what they're doing, Samir, is
Yes, yes.
placing the post-dilatation balloon distal marker just inside the platinum markers on the scaffold. And at this point, it's basically like
Down.
post-dilating any stent, but we'd love to see pressures of 18, 20 atmospheres.
And leave it about 10 seconds.
Yep, and make sure you leave it up long enough for it to have an impact.
I think I have to go in a little bit SS. See that dot? Dot, dot.
Chuck, we must leave the audience
Go up
with
here.
very clear guidance here.
Too far.
For operators nationwide starting out with this technology,
Go.
they should really be focusing on straightforward type A and B lesions, no?
I think so, but you know, you can move pretty quickly
Yeah.
to,
Right.
to
Get
B1 and B2s because that's mostly what you're treating these days in the cath lab. There aren't a lot of A and B1 lesions, certainly not here at Mount Sinai.
Well, this
But they
is,
get the
this is
toughest
all,
cases in the world.
This is all C2 territory.
Right, right.
C and D. That don't exist. Okay.
Now we go to bigger one anyway.
Okay.
Yeah, yeah. Just go with that. Yeah.
Go
Yep.
back with the 3.5.
Yep.
For the proximal area.
Yes.
Right. So basically, it's a very simple technique emphasis for absorb. We call it PSP. Prep the lesion, size appropriately, and then post-dilate. P for prepping, which you saw done with Rotablator and a good NC balloon pre-dilatation. Sizing to make sure that you've got plenty of room for the 0.5 millimeter expansion. And then post-dilatation, we're recommending 100% of the time, regardless of how good the implant looks after deployment.
I may recommend a little modification of that. I think it should be PSP with the appropriate imaging.
Yeah,
Got
there
it.
you go.
You know, because once you,
You want to see
because
proximally with
appropriate imaging would help all the three.
Right.
Yeah.
No, you're right.
Good.
So maybe PSPI.
Right,
20.
PSPI. So
Yeah.
I'm going to, at it's 9:30, 9:35, I'll proceed with getting name branding for
Go.
this. Chuck, where do your training travels take you from here today?
So headed to Nashville, Tennessee today
To the HCA group of hospitals?
to visit HCA, Vanderbilt, and St. Thomas hospitals, yes.
Wonderful.
Ready? Okay, OCT.
Beautiful.
Wow, it's beautiful.
All right.
Wow. Really, really nice.
And more importantly, the diagonal looks excellent.
Yes.
Yep. You can see, Samir, probably even looking at the screen as you are, that visually you can tell the step up from that post-dilatation.
Exactly, exactly.
Clearly a step up in lumen diameter compared to the immediate post-deployment. This is exactly what you want to see with Absorb.
So you would angiographically, you would predict that with OCT we should see excellent strut expansion right through.
Yes.
Samin, how high did you go with the non-compliant?
20.
20 for both the
Both
distal
of
and
yeah.
the- excellent.
What are you doing?
He wanted some.
Die from the other side.
Chuck, follow-up for these patients, anything different one should do?
Nope. Pretty much like any stent patient, 1 year of DAPT is recommended right now until we have more data on Absorb and DAPT. You know, it took a couple of years to get all the short DAPT data for all the drug-eluting stents. So it'll take us a couple of years to have enough data on DAPT
Ready?
for Absorb to recommend any shorter than 1 year. But what our OCT data shows at 6 months is that the struts are fully covered. So if a patient had to come off DAPT after 6 months, it should be safe, although I have to couch that comment in that we don't have actual clinical data on that, but we have OCT data showing that the struts are covered in many, many patients in OCT studies. So if the patient had a bleeding episode on DAPT or needed to have surgery after 6 months based on our OCT data, we would predict that it would be safe. But of course, we need to generate the clinical data.
Excellent.
So I think we're coming back to the point, Samir, that in this cases, that is there anything different? So I would say the different is I still will follow till we know that by our own experience, this BVS, the specific optimization protocol has eliminated or equaled the stent thrombosis. I would go with the BMS the data in the sense that if we think patient cannot take DAPT for 1 year, don't put the Absorb.
Right.
I think let's keep it there, because what is our biggest concern?
Absolutely.
Because knowing that the metal DES is more forgiving than the BVS, so till we know that yes, even 6 months we can stop. And so if there was one case actually I had, not clear whether he's going to take or not, we did not put.
Right.
Just
right.
last week.
I think that's wise for right now.
Yeah.
I did. Open
Okay.
better. Somebody has to hold the
What do you want?
hold that.
Okay.
Don't, because otherwise it'll
You know, Samir, the fact is that
ready?
do the OCT here and yeah, so Samir, the fact is that most of the patients being treated in the cath lab are actually acute coronary syndrome patients anyway.
Right.
So if they're non-STEMIs, STEMIs, or unstable angina, 1 year of DAPT is recommended anyway.
Right.
Guys, don't do that.
Chuck, my team here is providing me some data on how many live sites were watching us.
Ah,
And as Samin had predicted, it's I think today's program is going to have a much wider audience. So the number of sites, and some of these sites have anywhere between 20 and 30 and 40
let's
people.
just show the BVS.
Right. Anup,
Okay,
yeah,
right there.
I'll let you do that and then share with you the data.
okay.
Okay, just show us how the stent. Don't do any lumen measurement.
Yeah.
Stent apposition. Yeah. Okay.
Beautiful.
Yeah.
We call
Really
it a
nice
bricks.
expander.
You see nice bricks. The
Chuck,
bricks
I like
inside
that.
Chuck, you're happy with that?
Lego
It
blocks.
looks great. We
Nice,
call them
nice
little
apposition.
black boxes.
Okay,
I like
now
bricks,
from
though.
distal
That
to
works.
proximal, can you show us the stent? I mean, opposed.
Can we see
right.
the distal edge and
Proximal edge looks okay.
proximal edge, and then the distal edge?
Distal.
Looks like there's still some blood in the vessel there, huh?
I mean, we could not go more than this. We give 5
yeah.
at 15.
Yep,
Bigger
yep,
vessel.
Yep, yeah.
No, come back. Proximal. There's no stent there. I mean, okay, right there.
You happy with the expansion there?
Yes.
Okay. So Chuck, at the maximum we had 38 sites viewing us.
Terrific.
And I would assume that's from numerous countries. Traditionally we get large audiences from the US, very large audiences from India, and from numerous other countries. More recently a lot of interest from numerous European countries and Brazil.
Yeah.
Terrific.
Good. I think everybody looks at the last picture, looking very good.
Chuck,
Nice.
I always ask Anu to give a take-home message,
Yeah,
but what would be, since you are the guest there and the real expert, what would be your take-home
Yeah, let me just complete mine for next 30 seconds and then we'll go back to this point.
Perfect.
So therefore, take-home messages, the update in the BVS techniques and the PCI guidance with IVUS and OCT. So clearly the numerous studies of Absorb BVS have shown similar MACE with lower mortality and higher device thrombosis compared to metal DES with the techniques which we used. BVS specific implantation techniques have shown to reduce the device thrombosis comparable to metal DES and hence should be strictly followed. And clearly the avoid BVS in vessel less than 2.5, that's a general statement. And then of course the recent meta-analysis of the IVUS studies during PCI has shown lower MACE rates largely mediated by lower TLR and stent thrombosis by IVUS optimization. Ongoing randomized control trials will establish the role of IVUS versus OCT beyond angiography only in improving the PCI outcome. Quickly, 3 questions. One is the following statement is false regarding the published Absorb BVS trial data compared to the metal DES, that equivalent MACE, higher device thrombosis, equivalent or higher mortality, equivalent stroke or equivalent BARC 3 to 5 bleeding. So one of them is the wrong answer. Second, following BVS specific protocol for scaffold deployment have shown to improve outcomes except adequate pre-dilatation, post-dilatation with up to 1 millimeter larger non-compliant balloon at 12 atmosphere or post-dilatation with up to 0.5 millimeter larger non-compliant balloon at 20 atmosphere, minimal scaffold overlap and full lesion coverage. So clearly one of them is the one wrong answer. The third question is the meta-analysis of IVUS during PCI have shown to improve the following endpoints except lower stent thrombosis, lower MACE, lower TVR, lower MI and higher stent MLD. So clearly with those questions are always there, answers are on our webcast, and with that note we took a little extra time today. Usually we finish it in about 60, 70 minutes, but went through the lot of individual points. More importantly, that the side branch which we knew made this case complex, and that is what the whole case is all about, that we wanted to make it a complex case and go through the various steps to our audience, and I'm glad that results are excellent. Anu?
Samin, quick question before you proceed. Any plans for the circumflex in the future?
Yeah, well actually as we saw, both stress echo was only anterior wall and they did a FFR of the LPL which looks quite tight to me, but has been done is 0.87.
Okay, so we leave
So
it
therefore
alone.
we leave it with this patient who has just a minimal symptoms. He has a mild AS anyway, so he will be followed very closely for progression of both his aortic stenosis as well as CAD.
Chuck, comments first. Yeah, Anu, go ahead.
No, I was just making a point. Once we pre-dilated the diagonal, I am going back to the diagonal, how could we have made it simpler? That once we pre-dilated and placed the stent there, there was this debate, should we go further down and make the angle versus leave it alone. I think I was all for leaving it alone, but you know the other debate was to make that angle, and that is where I think we took longer once we decided we wanted to go further down. Before we started, our plan was before the bifurcation we just wanted to stay there, and if we had probably placed the stent just about there, we would not have taken longer for the diagonal. Just to tell you that could we have made this case the diagonal part simpler than the way we went through all the tricks of, if you get into the problem of you have a distal edge dissection of a calcific vessel, we showed you how to handle the stent placement distal to the stent in this kind of calcium and angulated vessel.
Right.
I mean I wanted the angle weighted because you see that on angiogram that angle has 50-60% lesion, proximal to that is that 70-80% lesion. So we thought that even if you put a short stent may not do a full justification, and more importantly in this particular case we wanted to avoid a chance of going back through the scaffold struts if possible.
Right.
So that was the reason. Anyway.
I think you did a great job, and I think I knew it was important to treat that little angulated lesion. It looks severe. I know it was hard to do. It would have been easier to avoid it, but I think you did the right thing.
Yeah.
I mean, that diagonal is completely revascularized. And then just 2 quick points on the LAD for Absorb. When we first looked at this film, we said, look at the calcification, right? But this shows you in the hands of operators that know how to do plaque modification with Rotablator. You could have used perhaps possibly even a scoring balloon or cutting balloon, but I think rotational atherectomy here was a great choice. The prep you got after you did that and then the NC balloon made a tremendous lumen for the delivery of Absorb. And I don't know if people were watching, but the Absorb went straight down without any resistance at all.
Right.
So that's what will make for a great procedure. And then as you saw with the post-dilatation, there was a big step up in the final lumen. Even without OCT, you knew that.
Yeah.
But I think it's fantastic to see the OCT. So congratulations on a great case.
And Samir, this could be the first in United States rotational atherectomy followed by Absorb case.
Absolutely.
I think so.
And I think numerous more. Chuck, feel assured we'll do our best job in teaching this technology to the world. Your presence today has added the intellect and the expertise, and I'm glad, as Samin mentioned, particularly I think he'll be a great demonstrator for this technology because of his insistence in lesion preparation.
Yes.
Anu, any final words from you?
No, I think we went through all the points with the lesion preparation for this great device.
And we hope to show numerous of these cases in the next several months.
Perfect.
Chuck, thanks
Terrific
again.
outcome.
Safe
Congratulations.
travels to you, and
Congratulations.
to all. We'll see you during our next case on August the 16th. Till then, good luck with all the BVS technology.